from Kenyan National Hospital, and Florence Waswa. We are starting soon. Actually, we're starting now. Welcome to today's session. My name is Dr. Rhoda Kalundu once again, and today we're going to hear an experience from one of our own, a Kenyan physician living and working in the UK, Dr. John Kibugi. Dr. John Kibugi is an emergency medicine physician, and I'd like him to introduce to tell us more about himself. Dr. John, the participants that we're having is a mix of, it's a multidisciplinary team. So we have clinicians, we have pharmacists who've also joined us. So we have a mix, a very good mix of people who are interested in learning and hearing how different the scenario is at the UK vis-a-vis the Kenyan picture. We also have Dr. Jeremy, who should be joining us to share the Kenyan picture, but we wait for him to join us, but you can start your presentation. So karibu sana, Dr. Kibugi, you can start.
Yes, thank you very much, Dr. Koduru, for the good introduction, and also thanks for all the people who arranged for me to give my experience down this end. First of all, to introduce myself, I'm Dr. John Kibugi. I graduated from the University of Nairobi, worked actually, interestingly, in Nyeri for probably 3 years, and then moved on to work in Nairobi Hospital as a senior house officer. Then from there, I just made my way to try and progress in terms of emergency medicine. My credentials are not much, but I'm a member of the Royal College of Emergency Medicine, and also I've done a diploma in acute medicine, which I currently practice in full. My current position in terms of in the administration curve, in terms of the emergency department, I am one of the senior specialist registrars. Currently, right now, I'm working in a hospital called Western General Hospital, which is near Bristol, and I'm currently also doing locums up and about. So I've done a few locums in London. So I've been asked to talk about my experience on COVID in COVID in the UK, and probably I think I'll restrict myself more onto the emergency medicine setup and setting. Also, at the same time, also try and talk about the patient's pathway, and the other thing is identification of patients, early identification of patients, which kind of pathway they should be put on to. And then I also talk about maybe the patients who you need to admit, the ones you need to discharge, and also a few rules of thumbs. And also want to also talk, maybe if I have time, to touch on definitely the key workers may get infected and what to do about it. So if I can just put a breakdown of what I'm going to talk about today. So as I said, I think I've introduced myself and the layout, what I'm going to do, and that's partially what I'm going to talk about. Maybe I should try and share my screen. Maybe that will help. Yeah, yes, so that's what I intend to talk about. So my current hospital I'm working at, or most of the A&E departments in the UK, have been, first of all, divided into zones. So zones have been divided into what we call a green zone. A green zone is where no non-COVID suspected patients or patients with COVID are managed. So this is what we call a green zone. This green zone is very, very far away from the other zones, and the personnel working in that particular zone do not interact with the other personnel of other zones. Then from there, we have what we call an amber zone, and what we call before was called a red zone, but we removed the red zone and called it actually a blue zone. The reason why we moved from red to blue is just because of patient's perception. If you're going to send a patient to a zone with people labeled as red zone, they think the outcome will be bad for themselves, which is not correct. So we change that into what is called a blue zone. So what actually happens in the amber zone? Amber zone is where you have patients who are suspected to have COVID or maybe confirmed COVID, but you are not instituting any of what we call instituting any aerosol producing procedures. In other words, you're not either ventilating or you're not also using the NIVs. So that is the amber zone. And then the red zone, or the blue zone is where you have all the other things. There's the intubation and there's the use of NIVs and anything else that constitutes aerosol producing procedure. So in our A&E department, we have both the amber zone and one to two places we call a red zone. So first of all, the blue zone, which, sorry, I'm calling it the red zone. The blue zone is situated very far from, not very far, but away from the amber zone. So in other words, if you are going to move a patient from the amber zone to the blue zone, it's a different particular zone, and there's a corridor pathway to go from A to B. Within the amber zone itself, we have two particular cubicles which were set aside. Actually, they are side rooms with proper ventilation and circulation and ventilation, so such that if you have a patient in the amber zone who either deteriorates or you need to resuscitate or you need to do any procedure that is aerosol producing. So it's good to remember something like even basically suctioning a patient who is actually vomiting or you needed to clear the airway before you do anything else. That's an aerosol generating procedure. So this should be done under proper all PPE in place, and also in what we call the blue zone. So these are the two side rooms which are within the A&E department. So in a nutshell, in our A&E department, we have the amber zone with two cubicles or two side rooms, which are the blue zones. The rest of the blue zone is away from the department, and there's a corridor to transfer this patient to that particular region. In terms of the staffing themselves, the staff who work in particular zones, so in other words, if you have a staff working in amber zone and a staff working in blue zone, they work that particular shift in those two zones and they don't interact. The only time you interact with particular people is when you're transferring patients. Other than that, so in terms of moving equipment and all those things, you have particular porters. If you need things moved up and down, you have just particular porters for those particular sessions, and they only work those sessions, those areas, all those sessions. So if you go down to, in terms of the amber zone itself, the staffing levels in the amber zone itself, we have both, just definitely we have all the people you need in an A&E department. It's very important, first of all, to make sure that actually the hospitals don't get contaminated completely, or there's no cross infections in the hospital. Sadly, in the UK, we've had now 2 hospitals which have been closed down because of actually inter-hospital transmission of the disease, and which was probably because of breakdown of the chain, or maybe the interactions of the staff. So which is, I think most centers should try and avoid this. So coming out from that, I'll just talk about the patient journey and how we manage the patients actually coming to the department. So in terms of patient journey, we have lots of patients. One, the patients who come with ambulances, and the ones who walk into A&E. So first of all, I'll talk about the ones who come with ambulances. So the ones who come with ambulances and they're suspected COVID, what happens is that the ambulance calls into to the department on a particular, we call a red phone, and tells about the patient. And then so that we can prepare for these patients, So once the patient arrives, the patient still remains in the ambulance, and just the crew gets into the department and gives us a handover about the patient so that we can then plan how this patient is going to come in. If the department has no space for this patient does not get into the department. The patient stays in the ambulance until we can get space for this patient. This is very, very important in that this stops any other, either one, contamination of the department, two, us having patients in the department of which we cannot manage or we cannot help. Because you want to get a patient into the department, a patient that you can actually manage and come up with the decisions of what to do with the patient. So going to the other part, what you call the walk-in patients. All patients who walk in, first of all, they present themselves at reception in an orderly manner, and once they give up the symptoms, then the receptionist decides, or whoever in the reception, which there is also a nurse in the reception, decides if the patient is actually a COVID patient or not. And if it's a COVID patient, then this patient is put in a particular room where the patient then is orderly moved to an amber zone where the patient is managed. This is again for us to be able to have patients that we can manage and also not contaminate the environment. So I'll go down to identification of the patient. First of all, it's good to So I think I'm having some technical difficulty here. So regarding identification of our patients. So first of all, as you know, when the patient comes in, we have to try and identify the patient, figure out how we're going to escalate this patient. So any patient who comes into the department is actually managed. So is it probably, I don't know if everybody's seeing what I'm seeing my presentation.
Hello, Dr. Kikbugi.
Yes.
No, we can't see your presentation. We can only see what is on your screen. That is the COVID-19 at the front door UK experience.
Okay.
Do you have any other slides other than the
Yes.
layout?
Yes.
Oh, okay. We've not seen them.
Sorry, are you able to see anything else?
No, we're still seeing that, the COVID-19 at the front door, the UK experience, just the layout of your presentation. You can email it to Dr. Kinudi and we'll be able to share it from our end if possible.
Okay. No, Nusha, sorry. Probably, have you got a Nusha now, management of suspected patient?
Yes, we can see that.
Okay, sorry, yeah, it's technical. This is my first time to present on Zoom to many people.
Okay. It's okay.
Okay, yeah. So I was going down to, first of all, in our identification of the patient. So to start with, the patients, we have to try and stratify these patients so that we can be able to manage them appropriately and figure out who we need to escalate. So as per the WHO classification of the disease itself, or the National Institute of Health classification of COVID, it goes to a spectrum where you have asymptomatic, moderate, mild symptom, moderate, severe, and critical. So identifying the severe and the critical, that is very straightforward. Even just on the bedside, you'll be able to identify this. The ones which are actually difficult to certify are the ones with mild and moderate disease. So first of all, I'll just take you through just a spectrum of the initial management and starting of the management of this patient. As you know, in an emergency department or emergency medicine, we all manage the patient in an A, B, C, D kind of assessment criteria. So in other words, airways, A is for airway, B is breathing, C is for circulation, which is blood pressure and the rest, and D is for, can I say, defects, in other words, the GCS score and the alertness of the patient. So when the patients come in, yes, we put on a SATS probe to find out what the saturations are, blood pressure, monitor to get the vital signs recorded. And here we have what we call a new score. In other words, we call it an early warning score, where all the vital signs are stratified in terms of numbers. And then after that, the numbers are then added up and it gives you a score. So a very high score, anything above 4 is somebody who is critically unwell, and anybody who scores 1 or less, it means the patient is a very stable patient. So the initial other thing, investigation done, as you can see in the flow chart, are all written down. So I don't think I'll go into the details of that. So the ones who have a mild disease, these are the ones who have saturations over 94% on air. And definitely you also have to think about the people who have type 2 respiratory failure, in other words, people with COPD. So those ones you are talking about saturations, anything above 88 to 94, depending on what their target or normal saturations are. And then goes to the other one is the moderate, which is SATs of 94 and less with a high respiratory rate of 20. And the severe ones is when you have SATs below 90 on air with saturations with a respiration over 30. So once we come up with, or we do the initial things, we go on to what we call our decided protocol depending on these patients. So we have patients that you'll need to, can I say, the ones who need escalations, the ones who don't need escalations. So this is where we are put in anyway, which is maybe a more difficult situation where you have to decide who needs escalation and who doesn't need escalation, who needs to go on a different pathway. Our department, or most all departments, have a clear protocol managing these patients so that everybody is singing from the same song sheet and patients are managed in the same breath for all of them. So all departments have a flow sheet, which I'll probably try and share 2 of them. One of them is the none for the one that you're going to escalate, and then the other ones, the ones you not for escalation. When I'm talking about escalation here, I'm talking about escalation to ICU or intensive care for further management in terms of supported ventilation. It's good also to mention that even if you're not going to escalate some of these patients down to ventilation, there's still room for NIV. And this is also should be considered for all patients that are present. If I can try and see if I can share the other. So give me a minute, I try and share the other flowchart that I have.
That's okay. I'd like to remind us, please remember to put your questions for Dr. Kibugi in the Q&A section. And it's good today, we're not seeing any concerns about CPD. Have you been getting your CPD points? Let us know.
I don't know if you're able to see my new share now.
No, not yet.
Not yet. Sorry, give me a minute.
Okay, so as Dr. Kibugi continues to get his slides, I'm seeing that quite a few of concerns about the CPD. I thought this was sorted out, but it seems we're still having challenges. Edward Kamau, we've heard. We'll try and adjust the sound on our end. Joyce Muigai, kindly let us know which professional body or association you belong to so that we're able to know who to follow about your CPD points. Your best Mukabe, same applies to you. Dilis Nyakiri, same applies to you. Let us know which professional association you belong to. Evans Rono, I'll follow up and find out if there was a delay in uploading it in the PPB portal website or what exactly happened. Dr. Kibugi, are you ready?
Yeah, are you seeing my new sharing thing? Or?
Let me just see. Yes, initial management of hypoxic patients with
Yes.
respect. Okay, yes.
Yes, so this is the initial management of the patients who are not for escalation. So when I say they're not for escalation, these are patients that are part the protocol has been put in place that these patients are not for escalation for intubation, but there is still room for NIV. So these are the patients, these are patients, either elderly patients, people with lots of comorbidity, people who have, in terms of quality of life, is can I say is less than other patients. So this is the flow chart it's been put in place for everybody to actually use it so that we can come up to these decisions. So there's something we call a French score that we use also to help us make this decision. So the French score, this is the French score which has been, that we use, of which Anybody who scores a 6 or more, this is the patients who are moderately frail or severely frail or very frail or terminally ill. These are the ones who fall onto this can I say, pathway. So once you have assessed these patients and you give them oxygen and decide they are not for escalation, you have these discussions with, if the patient is conscious and is able to communicate with you, then you actually let them know that that's the pathway they're taking. This is also, we have to involve one of the, either the senior person in the department, usually a respiratory consultant and an A&E consultant, who actually then agrees with you that that's the decision you're taking. And if you're taking that decision, then you think about offering them NIVs. So that is non-invasive ventilation. And if you make out this decision, then this patient is then moved from A&E amber zone onto the blue zone, which is not in the A&E department. And this then patient is passed on to the people managing, or the staff managing the blue zone. The staff managing the blue zone are the intensivists and associated personnel in that area. So A&E, in terms of us, we don't actually directly manage people in the patients in the blue zone. So if I can go back to, I can try and share this slide on. Try and share the slide on the ones that needs escalation. Hoping that I'll be able to get there. Sorry, okay, I'll just probably just go ahead and just discuss the patient the ones for direct escalation. And probably if you want these slides, I'm happy to share them with all of you. So in the first 15 minutes, all our patients, we give them oxygen. First of all, once we've discertified our patient as the other flow chart we said, once we identify the ones, first of all, who have low sats of 94 on air, we give them oxygen or non-rebreather mask and evaluate them for 15 minutes. All the ones that respond to oxygen, the sats go up to 94 and above, and respiratory rate drops below 30. We continue giving them oxygen for another half an hour and evaluate these patients and send them. And if at all they are responding well, yes, then we send them down to the wards with a clear guidelines in terms of this patient being monitored every half an hour, so that if at all the saturations drop, then they can be escalated to ICU in terms of other supportive measures, in other words, NIV or direct intubation. For patients who after 15 minutes do not respond to the initial oxygen by mask, we give them another half an hour on oxygen and see how they are responding. And if the results again go up, then again we give them another half an hour and then move them off up again to the wards on just plain oxygen. So the patients who after half an hour do not respond they respond to the oxygen itself are then escalated up to the ITU team, who then we have a discussion with them, and then if at all they agree with us, then they are moved into the blue zone, where they initially started on NIVs.
Dr. Kibugi?
Yes, sorry.
Yeah, your screen has, there's something on your screen. I don't know how to put it. It's showing your other open work.
Okay, that.
Yes, there. That's better. Thank you.
Okay. And what's on the other open work, or is it just my laptop stuff?
Yes, but now it's better. Now we can see the management, COVID-19 initial management of hypoxic patient. That now we can see it very clearly. Your
Okay.
flow chart, yes. Thank you.
So the one I was trying to, I was talking about is the one for escalation for this product. This is an escalation. I haven't been able to put the other one up. Okay. So the question is where, how do you determine if a patient has come in? Yes, you've done your initial assessment, and you've decided that this patient, yes, this patient probably has COVID, and you decided they're either in the mild to moderate disease, and you give them oxygen and they've responded to oxygen. One criteria that a lot of people actually have been going wrong is that a patient comes, they're given oxygen, they feel better, the SATs come to more than 96, you titrate the oxygen down, they feel better, the other saturates remains at 96. These are the patients who you actually need to keep a good eye on, because these are the patients who actually may drop their saturation very fast without you actually giving you any warning signs. So these are the patients who should not actually be sent away. The other group of patients are the patients who come in and they have mild symptoms, they have respiratory symptoms, but their SATs are more than 96 on air. And you are there wondering, oh, this patient needs to come in or not. We have what we call a exercise, exercise test for these patients to see if actually they're dropping their SATs. So what we usually do is that we walk them up and down in the department for up to 60 yards and then take their saturations. And if these patients, their saturations drop below 94, then means that this patient again is one who will require oxygen probably later and needs to be admitted. Regarding other things in terms of investigation, I know a lot of people talk about in terms of in investigation, one of the most, highly, one debatable procedure is arterial blood gases versus venous blood gases. It has been shown that anybody with the SATs of 94 and above doesn't actually need doesn't actually need an arterial blood gas to determine how hypoxic that patient is, because the marginal difference between the two is limited. In other words, there's no much significant difference. So all the patients who come in get what we call a venous blood gas when we are drawing all the blood samples. And if they require an arterial blood gas, so these are people who have SATs of 94 on air, are only ones who have an arterial blood gas done. The reason why we do this is because you don't want to subject these patients to arterial blood gases, which is painful, a painful procedure, which at the end of the day is not going to help you make a decision on that patient. So that's why we only do arterial blood gas if the SATs are below 94 on air. There's a question also, the other question about imaging. Our imaging, we result all our imaging to chest X-rays, and not anything beyond that. I know people have talked about ultrasound guided diagnosis, and also CT scan directed diagnosis. In terms of CT here, it's not done in the primary, in the beginning for us at all, and we have a laid down criteria for that. And one of them is, first of all, is a patient who you think has all the symptoms. X-rays have been negative, and this patient has been in the department, not in the hospital, for more than 24 hours with no other changes. That's when you can think about doing a CT to help with the diagnosis, even though it's not going to help you in terms of trying to manage these patients. On the other key things about rules of thumbs in terms of managing these patients, the difficult decision, or the patients that you don't want to miss, are the patients who need to be admitted and you send them home. So our one criteria is that anybody who comes with respiratory symptoms and is on between the 7 and 14 and has respiratory symptoms, despite the saturations being over 94, these are patients we actually admit for 24 hours to have a look at them and see which way pathway they'll go, because it's the most critical time of the disease. The other one is anybody who comes again with respiratory symptoms, but not in the initial phase, but starts of 94 and above, but has other comorbidities and all other risk factors, which probably everybody, most of the people know. Those are, in other words, if they're overweight, they are diabetic, they have heart disease, have respiratory problems, have renal problems, ongoing comorbidities, all those patients also need to come in. So generally, for us, for a rule of thumb, anybody who you're sending home, first of all, you have to look at the case in details about, one, where the patient is going, where the patient is going, how will the patient be able to get back or get medical help if they deteriorate. 3, are there any surrounding circumstances? In other words, is a young individual who is healthy, who has no other comorbidities, who has SATs over 94, and is only in the initial days, in other words, below 7 days of his infection, then these are the patients you can actually comfortably send home. Otherwise, the other ones, you really have to really think twice before you send them home. Now, in terms of, I'd say that I might maybe talk about infection of key workers. A few things I probably did not talk about is the importance of personal protective equipment. I think there should be an agreed, or all what here we have agreed protective equipment people should wear in particular areas, and whatever procedures they are doing, and whichever kind of patients they have. So like for us, anybody in the hospital has to wear a mask, a surgical mask. So not just face covering, so it's a surgical mask. Anybody in the amber zone has to wear a surgical mask. If they're going to come in contact with any patient at all, so this is a patient who are non-COVID, and are not anywhere in the red zone, they have to wear an apron and gloves. If you're going to be coming into contact with any patient in the red zone, or you're going to be in contact with a patient having an aerosol producing procedure, in other words, plain suctioning, or NIV, or intubation, or in a cardiac arrest scenario, all these people, members should have, one, a visor, or FFP3 or equivalent mask, full aprons, gloves. I know in any setup, in emergency department setup, sometimes a patient collapses and people forget other issues regarding their own safety. And also maybe the patient is either have vomiting or having a problem in the airway and they go and try and assist. In our department, we have a lay down before every shift, starting of every shift, we know which individuals are part of the resuscitation team, such that if any patient in the department collapses, this patient is just taken down to the 2 rooms I talked about before, which are the blue zone isolation rooms, where then the people who are supposed to be dealing with the resuscitation phase of this patient go in. So when the patient is being moved, the people who are going to take part or going to resuscitate or attend to this patient later on start gowning on their PPEs. Twice before we've been caught short where we failed to do this. I can talk about one instance where somebody came with came with a traumatic pneumothorax, and we needed to put it in a chest tube. And before we could put on the tube, that's when we realized we're actually doing a aerosol producing procedure. And despite this patient coming with trauma, yes, we had to move this patient down to the blue zone and down all the equipment that we needed. So this is how easily we can always forget. Regarding wearing the protective equipment. I think I've talked. I think I've covered quite a bit. So I think I'll leave it open for questions for now, unless somebody wants me to talk about anything specific in particular.
Thank you very much, Dr. Kibugi. Thank you for that presentation. Thank you for taking your time. I hope the participants have been able to appreciate the effort you put into. It's not what participants is for. Sorry. Thank you so much, Dr. Kibugi, for that presentation. I hope the participants have been able to appreciate the effort and the time that you took to prepare this presentation. Now, I'd just like to ask a question. Initially, when you started your presentation, you talked about referrals and you say that patients stay in the ambulance until they get space. So I just wanted, if possible, if you can expound on your referral process. How does it work? Is it that all patients are sent to a particular facility, but they have to call in advance? How does the referral process in the UK, in NHS, work?
Okay, the referral system works in 2 ways. One could be a general practitioner in his office sees a patient or comes or makes a home visit and sees a patient who is unwell and wants to refer this patient to hospital. So he calls in the ambulance, system, and the ambulance crew then is dispatched. Once the ambulance crew pick up the patient, they then assess the patient and decide if this patient is, how unwell this patient is. So as I talked about before, I talked about something called early warning score, where the vital signs are stratified and gives you a figure. So if this figure is high, while they're bringing the patient into the department, they call ahead and alerts us in A&E about the patient, what the patient presentations, what the vital signs are, what they've done. And then from there, we then make a decision where this patient is going to come into. So when the patient comes in, initially comes directly to A&E. So no patient goes straight to the blue zone. They all come into A&E, and then that's when we then do the initial assessment and then make a good, make a decision what else to do for this patient. There's something else I did not probably talk about, which maybe I can bring it out now. Any patient that comes into the department who is unwell, we have what we call a respect form. This is a respect form, is a form where which actually you discuss either with the patient, if the patient is conscious, or you as a clinicians make all those decisions and make a decision such that if this patient tends to deteriorate a lot, are you going down to pathway of full resuscitation, or are you going to put this patient down to the pathway of end of life pathway? So majority of these patients, because majority of them will be probably over 70 years old or 75 years old, you can have this good conversation with them, and majority of them will actually tell you that yes, if you get to a stage where there's no turnaround, they don't want to be intubated, they just want to go onto the end of life pathway. So if you have this discussion early on in the treatment, then it makes your work easier later on when things turn out to a different direction.
Well, that's very interesting. Are you giving the respect form to patients who are presenting with COVID, the severe and critically ill patients?
Yes. So it's not only COVID. Any patient who attends ED who is critically unwell or in a pathway that is unwell, yes, you have all those discussions with them.
Oh, that's really good. So you're actively doing resuscitation for patients?
Yes.
Because I'm seeing there's a question from Ziku Vincent, and he's saying, how are you going about active resuscitation of a sudden collapse of a confirmed COVID-19 patient?
So yes, this is where I never talked about it before. The history is very important when you're initially seeing this patient. A detailed history about, one, past medical history about this patient. Two, what I talked about, I showed before, the frailty score. So he's even if he's an 80-year-old, very fit individual, does most of his stuff by itself, had he got on any comorbidities, then this patient is for full escalation. So if they collapse in the department, you actually move the patient into, as I said, when they collapse in the department, there's a staff who are with that patient, we just put the patient on a trolley and move the patient onto the isolation bay, and then the people who are in the beginning of the shift have been demarcated, or they've been given the role to resuscitate, are the ones who go in and move into the area and try and deal with the case.
Thank you. Thank you for your response. There's a follow-up question from Dr. Ombani. You answered about the chest X-ray. You said that you're not doing any ultrasound or CT scan. Your primary or the ideal is the chest X-ray. So Dr. Ombani is asking, at what interval is the chest X-ray repeated? And
okay.
When do you decide on a CT scan, if you ever do any for the patients?
Okay, so in terms of X-rays, first of all, it is in terms of X-rays, once you do the initial X-rays, if it doesn't show anything, or it doesn't show anything, and your blood tests, when you've done your blood tests, they confirm more towards COVID. In other words, high CRP, high D dimers, and also and then the lymphopenia. If all these things are confirmatory, and plus their PCR test is also positive, you don't need to repeat an X-ray on this patient, because it's not going to help you in terms of managing this patient further. What's going to help you manage this patient further is actually your oxygen saturation, respiratory rate, and how the patient is. So an X-ray getting worse does not point the patient towards further support in terms of oxygen support, as long as you give them oxygen. So in other words, we've seen patients whose X-rays initially if you look at them, they have a lot of opacity, the glass opacities of the way they look, and they don't require actually more than just oxygen itself, while other patients they have sats of below 90, and the initial x-rays are very clear. So we actually give up to 48 hours to repeat another x-ray. And if that's still, it's negative, that's when we go on to a CT.
Okay, thank you for that. Are you doing self-isolation, or what is referred as home-based care? Is it being done?
In terms of I don't understand, the self-isolation of the patients, or sorry?
Yes, of the patients.
Okay,
For the
yes.
symptomatic patients, the less severely ill.
Yeah. So
yes.
The asymptomatic patients or the patient with mild illness, yes. One thing you have to do is actually sit down with them and actually explain to them the importance of self-isolation. A lot of patients think, okay, self-isolation is for them to stay at home, and then the other people around them can intermingle with the rest of the public. So self-isolation means that individual isolating plus the members of that household the patient has been in contact with. So in other words, in terms of shopping, getting groceries, other things that they require during the isolation is done by other people and delivered in a non-contact way and with social distancing. We've had cases where we've had patients admitted into the hospital, even into intensive care, and then you have relatives wanting to come and visit, and then you ask the relatives, oh, who is this to you? And they say, oh, it's maybe somebody they share the same household with. So you can see, ideally, you have a patient who is actually positive, who have other contact people, but they themselves don't think they need to isolate.
Okay, thank you. There's a very interesting question from Priska, but I'll not ask the way she's asked. She's just asking about what we can do differently, because we're now in Kenya, we're slightly over 10,000 cases and almost 2,000, less than 3,000 recoveries. So what lessons, the way I'll frame this question is to ask you, what lessons have you learned as a frontline healthcare worker managing this COVID-19 disease, and how different can we apply those lessons here in Kenya to have better outcomes for patients? Because today, I'm sure everybody is shocked by the news that we've lost 12 patients today, and it's not a good trend. But how best can we manage our patients so that we have better and good outcomes?
Okay. I think the first thing is, first of all, it's early identification of patients and escalation. We've noticed that patients who we identified early who are at risk with all the risk factors. In other words, if you have all the risk factors and you identify this patient early and you escalate them early for just plain supportive ventilation, so NIVs. I don't know about NIVs back in Kenya, because at the time I think I practiced in Kenya, which is probably 18 years ago, NIVs was not that popular. So, but I attended a conference sometime 3 years ago, and it was an emerging kind of practice out there. So I don't know how much NIVs you have there, but that's one way. Secondly, it's the mild and moderate patients. Knowing the correct patients to send away home and the ones to keep an eye on are the ones actually you're going to actually save, because the patients who have severe or critical illness, those are easy to get off or to identify and manage them appropriately. But the ones with moderate disease who may later on develop oxygen requirements are the ones who actually look out for. And as I said before, I think one of the good tests is the exercise, like an indirect exercise tolerance test. Make them walk up and down, take their saturations, and if their saturations are dropping below 94, yes, that's a patient you don't send home.
Okay, thank you. So we just have to have a key index of suspicion. Patients who are unwell, we identify them early and we manage them actively. And also like that simple test that you're doing where you're making them walk a few, but how fast are they walking?
whatever you see, you ask them, first of all, how they, definitely you ask them how they normally mobilize. So
Yes.
somebody who is 95 or well, say 65 years, you don't expect him to walk as fast as somebody who else who is probably in their 40s. So what normally I do is then ask them, can you walk the way you normally walk with me? So they'll come walk that pace with you. So that's our way we figure out what the pace they'll be walking out. But at least 60 yards
Okay.
in taking their saturations.
All right. What kind of PPE are you wearing? That's from Dr. Phoebe Juma. And she's also asking if the doctors and nurses who are on the front line are using Hamzat suits and N95 throughout when dealing with patients who have been confirmed to have COVID-19.
Okay, this is why we have what you call a catch-22 situation. First of all, if you are in a non-aerosol generating area, in other words, where no ventilation, no high flow, no intubation is being taken, in other words, there are no aerosol around, then as surgical masks is all that is appropriately to be worn. If you are in the blue zone is when then you have to have the FFP3 or equivalent plus a whole gown or the suits and a visor. If you are in the amber zone, in other words, in a COVID patient area or suspected, but has no aerosol generating procedure, and you are going to be in contact with that patient, then gloves, aprons must be worn and discarded as they are. The second place is the other second thing is the staff themselves have to have a health risk assessment. So in other words, all staff in the department have a health assessment, risk assessment. So in other words, patient, if asthmatics, diabetics, anything, the comorbidities that can make you more susceptible to getting COVID and making you, even if you have COVID itself, will make you actually more unwell than the normal population, then these patients should not work one in the blue zone. And if they're in the amber zone, they need FFP3 or equivalent masks. So it's a twofold. I hope I've answered the question.
Yes, you have. Question about what other questions are on the respect form. This is from Dr. Gishuri. She's saying, and she's also asking for clarification. If you said if the patient is unconscious, the medical team makes the decision. So who in the medical team makes the decision? Is there a team that discusses ethics? Yeah, so maybe you can expand more on that respect form, because I think it's a good idea which we can adopt here at home. It sounds like a simple form. I don't know if you have it and you can display it on your screen so that you can see the components of what is there.
Oh, sorry, I did not have this. I did not have this respect form. But if you want, probably I can send you later on once I get it. It's not. I didn't.
That would be great. Thank you.
So the respect form is a plain form where it has elements where you've discussed with the patients and patient's wishes. So when you say discuss with the patient that you let the patient know that yes, they have this disease, but yes, it's manageable, but there are times that it can turn around, and because of the patient's own risk factors, things may turn to the worst. And on that form, then you ask, according to that form, you ask the patient what their wishes are. Some of them will tell you, yes, you can continue until NIV and I don't want anything more. Others will tell you, I don't want anything else. It's my time to go. Others will tell you they want full escalation. So the ones who tell you full escalation and you as a clinician and other clinicians think differently, then it has a two, on the respect form has a two pathway. In other words, there's one pathway where you'll sign as yes, that's the patient's wishes, and also you agree with the wishes. And the other one is yes, that's the patient's wishes, but your decisions are different. So where you have decisions are different, two clinicians sit down and agree that this is the way forward. And for this kind of patients, probably you'll try and manage them until NIV stage, and that's it. You don't go into full escalation.
All right, thank you. How many patients or relatives gladly accept to end of life, but don't actively resuscitate my patient? Because these are some of the things that probably we might have issues with, where the relatives feel you might not have done enough for their person. But I agree with you, with correct information and that conversation, having that difficult conversation, it might be a start. And I think it's something we need to adapt here back at home. It's a good conversation to have. So, Doctor, we would really appreciate if we can get to have a look at the respect form and see what we can adapt, how we can also use it to in our setup.
Yeah, I'll be
yes.
happy to share with that with you.
Thank you. Thank you very much. There's a question from an anonymous attendee, and he's saying, if the test results take 3 days, when next should a patient be tested? How long are your test results taking, and which tests are you doing? There's also a question about antibody, whether you're testing for antibodies in COVID-19 patients.
Okay, I'll start. First of all, I'll start with the easy one. I'll see one is the antibody testing. We are not testing any patient any antibody testing because it's of no benefit in terms of in terms of managing your patient. Number two, antibodies have been known. I mean, the IgG and IgM, they tend to raise up to 3 weeks post-infection. And three, the current tests in the market have a specificity of between 87 to 90%. So all those things put together, it's been shown to be of no benefit actually doing antibody testing. So what we do is what you call a PCR, and ours initially when we started, because of reagents, used to take up to 48 hours. Now we've had a turnaround of 3 hours. So right now, in 3 hours, you get the result. So I don't know about the Kenyan situation. So if it's taking up to 48 hours, repeating tests are only beneficial if one patient has all the classical symptoms and the first test is negative. Wow. Otherwise, repeating the test, even if the patient has recovered, is of no benefit. The reason why we say it's of no benefit, it's only beneficial if the patient is within the 14 days and you're sending them home. If it's after 14 days and they have no symptoms, they'll still continue shedding the virus, but the virus is non-infectious. So repeating tests to somebody who's finished 14 days and is asymptomatic is of no actual benefit.
Thank you. I wanted to ask about healthcare worker safety.
Yes.
Yes. Today we just buried a healthcare worker who succumbed to COVID-19. May her soul rest in peace. And I can see also over the weekend, there were reports that previously we lost 2 nurses. So I wanted to ask about healthcare workers. Do you have any reported cases of healthcare workers getting infected while giving care to their patients? And there's also a question from an anonymous attendee regarding COVID-19 mortality in Blacks, that's including healthcare workers such as African doctors in the UK. So might you have any statistics on our colleagues from the UK who've been infected while giving care?
First of all, okay, in terms of infectivity of care workers, actually this I think happened. Majority of them happened early on in the start of the whole pandemic. The reason why I think it was a combination of 2 things. One, the PPEs were not appropriate. 2, there were no clear pathways of managing these patients or suspecting these patients. And 3, which is happening now, there was no actually risk assessment of the staff before being deployed in particular areas. So in terms of how many healthcare workers have passed or have been affected, I don't have the numbers off head, but I think they were up to 52, I think, but I don't have the numbers off it, but there's a significant number. And worryingly, that majority of them were, can I say, non-white. And the reason for this has been put down to multifactorials, but studies have been done to find out exactly why. So I cannot give you the reason, or we still don't know the exact reason why. But what NHS have adapted is what I've also mentioned before, is risk assessment of all staff members, such that the people who are, according to the risk assessment, who are high risks, in other words, asthmatic, diabetes, or other comorbidities, then these staff members are not put directly in line to where they will be exposed to the virus at a higher level. The other thing maybe I mentioned before is that we have people working in particular areas in a particular shift. The following shift, they work in a different area. In other words, if you have people working in the green zone and the amber zone and blue zone, they rotate around. The reason why, as long as they are low risk. The reason why we do this is that the less people are exposed to the virus, because the degree of viral load also plays a bigger role in terms of infectivity. This also reduces this.
Thank you, Dr. Kibugi, and I'm glad that now you're having less number of healthcare workers who are infected. There's a question about PPE, and June Mora is asking, how are you ensuring that you're not running out of PPE at the facility level?
PPE it's applied by the whole NHS chain. So they've put things in place, and we haven't run out of PPEs at all. And right now, actually, I think we have excess now because I think they overpurchased, and we are now down the curve. So the incidences are less. If I can give you an example, yesterday, I think I personally dealt with only 4 patients who are suspected of COVID, compared to 2 months ago, where every hour I was dealing with around 4.
Wow. All right. Dr. Amina Guled is asking, do you only collect nasopharyngeal swabs, or do you take sputum and fecal matter also?
No, only nasopharyngeal swabs only, because they are the most dependable and the most you can repeat them. Sputum, we don't do them because if you're going to produce, somebody's going to produce sputum, that's an aerosol generating procedure. You're putting other people at risk.
Okay. Thank you. And one of the questions is, who pays for the bill? And this was from Dr. Wambani. She was asking if you can give a rough estimate of what it takes to manage a COVID-19 patient. So who pays for this bill? Are they all covered under NHS, or is there private insurance that also covers the patients as they come in requiring different levels of care?
Okay, here the NHS system is, I think it's a very good system. It's a government-based system where what happens is that people pay in the form of taxes for the services, in other words, through their taxation, so that nobody pays anything at the door. So in other words, zero bill to the patient. So in terms of cost of managing a patient with COVID, I don't know the cost of it. Sorry.
All right, thank you. There's somebody saying my cousin in the UK told me that non-whites, the blacks, are dying of more COVID-19 since most of the whites ran away from workplace, so the blacks remained working and they're exposed. Um, I don't know. Is that true? How true is that?
That's not true. That's not true. No, that's not true.
Mhm.
In terms of, as I said before, that majority of people who have been affected are non-whites, but the reason why I personally, okay, they put a study in place, but if you ask me, the reason why majority of them are happened is that majority of places where actually COVID-19 was highest was in regions where the deprived are. In other words, somewhere in East London, some parts in Birmingham, some places up north. And these particular places are where also the non-white reside. So if you are non-white and you reside in London and you are a doctor, you'll definitely work in London. So you'll be more exposed to the virus. So you'll be more likely for you to get the disease. So as I said, it's multifactorial. So I personally, even though it's been put that, yes, numbers showed big numbers are non-whites, I think the jury is still out.
Okay. All right, thank you. But that's also a lesson to us that when we hear from somebody, it is not always true. It's always good to verify our source of information. So thank you for the participant who asked that question. I hope that has been clarified by somebody who's actually on the ground. Do you test your healthcare workers, and how frequent or often do you do it?
Oh, healthcare workers, the only time they are tested is, first of all, we have a protocol where if you're a healthcare worker and you develop any of the symptoms, you self-isolate for 7 days and your family members for 14. And then that, when you have those symptoms, that's when you're tested. So we don't do blind testing for asymptomatic individuals. So that individual is tested. And if he's positive, then stays away for 14 days. And if he's negative, then after 7 days can return to work as long as has no symptoms. So in other words, if you have symptoms and you're positive, you stay home for 14 days plus your close contact. If you have symptoms, you're tested, you're negative, and after 7 days, if you're symptom-free, you can come back to work.
Okay. Thank you for that. From Dr. Diana Marango, she's saying, thank you very much, Dr. Kibugi, for the very informative talk. Very nice that you're using non-invasive ventilation in your setting, and also very well thought out and written guidelines. For patients who are initially hypoxic and the saturations have gotten back to normal, that's above 94%, how long do you monitor them with pulse oximetry? Is it 24 hours? Is it 48 hours? And as you respond to Dr. Marango, there's somebody who asked, what is non-invasive ventilation? So maybe you can pair those two up.
Okay, well, that's the easy one. What is NIV? Non-invasive ventilation. This is where you support the person breathing without using direct intubation. So it's a face mask which is applied onto the face and strapped onto the face, and then you you apply particular pressure. So you can either use what you call a CPAP, positive. You use in other words, use a pressure to help the patient breathe, and this is you adjust this according to the responsiveness of the way the patient is responding in terms of the saturations and the blood gases. NIVs are only used in a patient who is conscious, in a patient who is willing to use the mask, because you can have a patient who is demented or doesn't want to use it or is confused and cannot use the mask. Yes, so a patient who is conscious, who is willing to use the mask and understand the use of the mask, And the other bits of it is that, yes, they don't have an pneumothorax. So you have to have taken an X-ray before you start using it. So in terms of the saturations, talk about if given somebody oxygen and saturations have gone up to beyond 94, how long do you observe this patient? So first of all, you admit this patient and you keep monitoring this patient. So as long as the patient has symptoms, in other words, apart from the improvement of the saturations, as long as the patient has symptoms, in other words, spiking fever, lethargic, anything else associated with COVID, yes, then the patient stays until those symptoms are reversed.
Thank you, Dr. Kibugi, for that. And my final question, this is from Lawrence Agunda. It's on a light note, and he's asking, can we let Doc touch on why, despite the effective measures put in place to ensure APL players are COVID-free in a developed world, yet once in a while, we get some players confirmed positive? And concludes by saying, I'm sure you must be a big fan of the game. So how have you been able to, okay, this might not be, you might not be in a position to answer it directly, but how have you been able to return back to normal and reduce the infections? Because that's one thing we are trying to do. Last week, was it last week? I think a week or two ago, we reopened up the country. It was open, but now we started some of the business activities resumed. And this week, I think the local airlines are starting. And 1st of August, we're having the international airline starting. We're seeing quite a few hotels have opened up and resuming business as usual. So how do we manage to keep our numbers controlled? I know we will get to a point where we may not be, because today's headlines were a bit scary, but we'll get to a point where we may not be able to keep the numbers under control. But we've seen that you've tried in the UK. So how do we go about it? Resuming our activities and protecting the rest of the people in that work environment. How do we go about that?
Okay, I think I'll just base my answer to that question on just WHO, which I think those are the guidance which I think the UK used. Number one is, first of all, the people at risk, shield them. So all the people at risk should be shielded. Two, the bit about masks. I know masks have been controversial from day one. One thing the masks does is that, and the other thing is the appropriate masks. So I know people are using face coverings and all that. The masks should be able to be at a level of a surgical mask. So individuals just taking a piece of cloth and actually cutting into a mask and putting it, I think that does not actually meet the full criteria of a mask. So a mask up to similar to a surgical mask is the ideal mask to use. And one thing the mask does is that it actually reduces transmission. That's one thing. And two, it is moderately stops one getting an infection. So at least if you stop the infection or reduce the mode of passing on this infection as a droplets, then the spread of disease will also go down. Three is social distancing. We all know it's kind of difficult to maintain social distances, but where we can, that's one thing we should always strive to do. And that's one thing the UK has tried. They tried as much as possible. And that's why before the peak of the illness, social distances was the key thing. And then number four is question of hand hygiene. Yes, hands to be washed as often as possible, sanitize the hands as much as possible. If an individual touches anywhere another human being has touched, no matter if you know that human being or you don't know that human being, then hands should be sanitized or cleaned. Unless you're in the same house bubble, in other words, same bubble. In other words, if you live in the same household, then that will be difficult to achieve. The other thing is that I know the question of people always say yes, water is an issue in the developing countries, but we can try as much as we can. And I think alcohol gels are probably easily available. I think I've given that answer, that question justice, I think.
Thank you. Yes, you have. And the headlines actually, let me read for you from the Daily Nation today. Waiting to explode. That was the headline for today's newspaper. And they're talking about our level of preparedness, the issues we've had in testing, the exodus to rural areas. So we wait to see. But I know that I said that was the last question, but two more questions have come in, and this is from Joseph Mutua. I'm not sure whether you'll be able to address this being an emergency medicine physician, but I know you'll give it a try. He's asking about management of suspected pregnant women, especially intrapartum. And the second question is from Dr. Momanye. He's asking, do you routinely anticoagulate your patients, and what's your what's your take on the routine use of steroids?
Okay, I'll start with the easy ones. Steroids. Steroids are, which is dexamethasone. We give it to all the patients that require oxygen at the way it starts. So if your patient comes and require oxygen at the start, then they are given dexamethasone. The other issue was pregnant women. Pregnant women are not managed as similar as patients who are not as similar as patients who are not pregnant. But the caveat here is you have to really keep an eye on these individuals because of two things. First of all, the tidal volumes of these patients are less than normal patient. Two, the hemodynamics of these patients are different from other patients. So other, can I say, pointers or warning signs in terms of sepsis or drop of blood pressure will come up much later because their volume is actually up. And three, there are two individuals. There's the mother and the baby. So in terms of pregnant, if a patient is pregnant and has symptoms, whatever symptoms. So in other words, if they have fever and you think have COVID, they don't go home, no matter what their saturations are. And I think there was a third question. I can't remember the third question.
Anticoagulants.
Oh yes, anticoagulation. So anticoagulation can I say that it's a tough decision for anybody to give. So our experience with anticoagulations, the ones we anticoagulate are patients who, one, are in critical illness, have low SATs and critical illness, and they have very high D dimers. And we actually go ahead, these are the patients, then we also go ahead and do CT, we scan them. And once you actually scan them, we do CTPA to look for pulmonary embolism. And if there's a lot of clusters of actually showings of PE, those are the ones we anticoagulate. So we don't routinely anticoagulate all the patients who are critically ill.
All right. Thank you so much, Dr. Kibugi, for your time. We truly appreciate that you're able to take time and come to talk to us. What time is it right now?
It's 1:25 for me.
All right. Thank you. Thank you so much for that. We've learned quite a bit, and I hope we'll be able to share the flow charts that you had, yes, and also the respect form. Thank you so much for that.
Okay.
The rest of the participants have seen quite a... Yes, continue.
Oh, I think also thank you for inviting me, and anytime I'm happy to share any other information either on COVID or on my field of interest, emergency medicine. Yes. And on a lighter note, I'm from North London, so Emirates is just not very far from me, and I'm an Arsenal fan.
All right, thank you. Thank you so much, Dr. Kibugi. Thank you for taking time. We appreciate that. We always appreciate when we get experiences from our fellow Kenyans who are out there doing great work. We learn something from you, and you're able to relate also to our local scenario. So thank you. Now, to the rest of the participants, I'm seeing quite a bit of concerns about CPD points for pharmacists and pharmaceutical technologies. I'd like to thank the team that has been handling that. That's Dr. Roslyn Kinuthia, Dr. Awak. They have a team that has been working on that. But I can see from what Dr. Raj has commented that they're still having issues from May, June, and July. Some people have not gotten their points up to now. We will follow up, but remember when we streamlined with the PPB from 15th of July, you should be able to see some change. 15th of July is 2 days from now. So let me know 2 days from now whether you'll see some change in the issuance of CPD. The PPB worked on something, they streamlined the process with the KNH team. So from 15th of July, you'll be able to see some change. For the Nursing Council of Kenya, members of Nursing Council of Kenya, thank you for always attending these sessions. Rose Njoroge has also been trying to streamline that and get NCK to make the process simpler. So in the meantime, we still have to sign your book until that process is streamlined. Thank you very much for always attending. Please feel free to pass by the KNH Research and Programs Office. Look for either Jacinta or Mr. Mwenda, and they'll be able to sign your book for you. You'll be able to get your points. And yes, once, Rose, you'd asked about backdating. Once we are able to get a simplified process with the Nursing Council of Kenya, we'll go through our database from March. All the Nursing Council members who've attended, we will issue you, not unless the Nursing Council tells us we cannot backdate, but for us, we're willing to issue you with your points as long as you attended our sessions. To the rest of the participants, thank you. We have 2 sessions today. In the evening, we'll be talking about triage and escalation from the community. What Dr. Kibugi brought out very clearly was that issue of referral of patients. When a patient is being referred from one facility to another, escalation of care, and how they triage the green zone, the blue zone, the amber zone, how they manage their patients while still continuing care for the other patients. That came out very clearly in Dr. Kibugi's presentation. So in the evening, we'll also see a picture from Seattle, USA, and compare with that. So that at the county level, I'm seeing there's a comment from Kennedy Ambunya, who's saying, counties, we are not ready. Yes, he was worried that we might not be ready at the county level, and we are not taking this seriously. So as healthcare workers, we are the ones to streamline our facilities. I know there's a role the government, the national government plays, there's a role the county government plays, but there's a role that you as the frontline worker will also be required to play in this so that you protect yourself. So kindly let's log in at 7 p.m. to know how best to triage our patients and about escalation. I know right now the government has said there's no transfer of patient from one county to another. You cannot refer to KNH or KU. So let's learn about how best to manage our patients and what we can do with the resources that we have. So look forward to seeing you at 7 p.m. Have a good afternoon. Bye. Thank you, Dr. Kibugi, once more. I truly appreciate it.
Thank you.